Well, welcome everyone. Bienvenue à tous. Je suis Susan Law, I'm the Managing Director of CanCOVID, and I just have a few instructional comments before we really get started. Et veuillez excuser mon français. Today's presentation will be in English, but we will have simultaneous translation available in French. Please go to the bottom of your Zoom screen where you will see an icon of a globe. Click on that and you can choose French if you would like to hear today's presentation in French. La présentation aujourd'hui se ferait en anglais, mais nous présentons une traduction simultanée en français. Pour nos participants francophones, veuillez vous rendre au bas de votre écran Zoom, cliquez sur le globe et choisissez French si vous voulez écouter la présentation en français. So you can please go ahead and select your language preference now. C'est le moment de sélectionner votre préférence linguistique maintenant. I'll just start by saying thank you so much to the Chief Science Advisor and her team for this opportunity for CanCOVID to work on this extremely important issue in Canada at this moment in the pandemic and pandemic recovery. I'm delighted to welcome all of our presenters, the attendees, Dr. Niemer as Chair of the Task Force on Post-COVID-19 Condition, also known as Long COVID, our moderators and other task force members. The task force is a panel of scientists, researchers, and clinicians, all with expertise related to different aspects of post-COVID condition, formed by Dr. Niemer to develop a roadmap to improve the health system response and ultimately the lived experience of post-COVID condition or long COVID. The purpose of this meeting is to hear from those with lived experience. As you may know, the task force is under very tight timelines to produce their report, given the urgency to support improvements for Canada and Canadians. A very special thank you and apology to all speakers today for agreeing to join us and share their perspectives on very short, and some would say unreasonable, notice. We sincerely acknowledge and appreciate what it means for you to be present and to present to us today. Please do pace yourselves. Your perspectives and voices today are critical to the structure and fabric of the report. Please also know that the task force will welcome any further information if you need more time or would like to share further information, which can be submitted after this session. And we have a brief update on the speakers. We have Dr. Manali Mukherjee, maybe a little late joining us. And for everyone to note that this session is being recorded and will be posted afterwards on the CanCOVID website. So without further ado, I will pass it over to Dr. Mona Niemer, and she will provide a brief welcome and introduction as well. Thank you, everyone.
Merci beaucoup, Susan. Thank you very much, Susan. And thank you to all the task force members who are joining us this afternoon. Bon après-midi, tout le monde. Un énorme merci de vous joindre à nous, et particulièrement pour les panélistes qui sont, c'est vraiment pour vous qu'on fait ce travail afin de pouvoir faire des recommandations pour la gestion de la condition connue comme post-COVID ou long COVID au Canada. So thank you so much. We really appreciate everyone's effort to be present, and especially for the individuals who are living with the condition. You are really at the heart of why we have this task force and what we're trying to do, that is to provide recommendations for the best management of the various aspects of the post-COVID condition, known also as long COVID in Canada. So thank you very much. We really appreciate that you're here, and we really appreciate not only that you've taken the time, but also the efforts that it takes on your part. As Susan said, you know, please take the time that you need to take to provide us your perspective. Your perspective is extremely important to us. So this very important roundtable is taking place as part of the thematic roundtables that the task force is undertaking to engage with practitioners, with experts in clinical care and research, in basic science, to understand the mechanism, the causes of the post-COVID syndrome, the socioeconomic impact as well that's been discussed, and of course the perspective from people living with the condition is extremely important to inform our thinking, to inform the research priorities, to inform the action priorities in general that we need to be contemplating. So, we're here really to hear from you and to listen to you as well. Again, we are on a very aggressive, I would say, timeline. We're hoping to have our report publicly available by mid-November. And that's why we're having these accelerated and very short notice meetings. So thank you for bearing with us. I guess maybe before introducing the moderators, so I'm grateful for two of the task force members who have agreed to moderate this roundtable. And I'm gonna be listening in like many of you. But before introducing them, maybe I'll just stop here in case there are any questions from the task force member or the panelists for me. Otherwise, I will just continue. Okay, so not seeing any question, I'm going then to introduce the moderators and get on with the session. So it gives me great pleasure to introduce my two colleagues, Dr. Angela Cheung and Dr. Don Vinh. So Dr. Cheung is a Canada Research Chair and a clinician scientist at the University of Toronto. She's among her many responsibilities, actually, she is the co-lead on what we call the CanCOVID study, which is a longitudinal study to follow individuals infected with COVID for up to 2 years. That's at least for now, the timelines. So she has a deep knowledge and interest in the condition, and we're grateful that she's with us. The other co-moderator is Dr. Don Vinh. And Dr. Vinh is an associate professor at McGill University. He's a clinician scientist who's an expert in infectious disease and immunity. He's the director of the Center of Excellence for Genetic Research in Infection and Immunity at the McGill University Health Center. He's also the director of the MUHC COVID Biobank. So he has as well a long-standing interest in understanding genetic susceptibility to infection and why infection affects people in different ways. And he has been extremely active and committed during the COVID pandemic. So we have two outstanding clinician scientists here with firsthand knowledge of COVID, who will lead us through this session. And again, merci Angela et Don d'avoir accepté de faire ce rôle très important. Over to you, I think, Angela.
Great. Thank you, Mona. So I also want to extend my welcome to everyone who's on this webinar. I just want to give everyone a roadmap of what we're going to do over the next hour and a half or so. So we're going to ask each of our invited panelists, and these are, there are 8 of them, but one party cannot join today, so there's 7. And each panelist will give a 5 to 7 minute kind of presentation, mainly to answer the 4 questions. We have 4 guiding questions around knowledge gaps, healthcare services, broader social impacts, and overall system support. So they will present. These are the speakers, and Dawn and I will introduce the speakers. After that, we will open for questions from the task force first, and then followed by sort of an open session for questions and answers to all attendees of this session. And we welcome people putting things in the chat. Questions as they come along as well. And I will try to monitor the chat, and CanCOVID will try to monitor the chat as well. With that, I just want to pass it over to Don, my co-chair or co-moderator, to introduce the speakers.
Well, thank you very much, Angela and Mona, for that. So we know there are many ways people can experience post-COVID conditions, and we're very fortunate enough today to have several speakers educate us about their experience and perspectives. So here our panelists will provide a statement on their lived experience. First up, we have Dr. Anne Bhéreur. Dr. Bhéreur est médecin de famille. Elle est professeure adjointe de clinique à l'Université de Montréal. Elle est aussi co-directrice et patiente partenaire dans l'axe de rétablissement dans le réseau québécois COVID pandémie. Et donc, avec plaisir, je présente Dr. Bhéreur.
Bonjour, merci. So I'm just going to share screen. Oh, great. So I'm going to start right away because we don't have much time. So as has been said, those are my disclosures, but you can read them later in the document if you like. I have long COVID since having COVID in December 2020, so I'm absent from clinical duties since. All of this will be just a glimpse because in a few minutes I can only fly over the huge amount of issues raised, and I won't be able to really go over the positive side, but I just want to say thank you to all the people I know and all the people who've helped me in those last 2 years. But today it's about the abyss before which so many people are within long COVID. And there's going to be a lot of slides and a lot of words because my voice is not really something I can count on. I have a sequelae, which is fortunately rare on vocal cords. So, and this is a part of my umbrella, which resembles a lot of other long COVID except for the vocal issues. But this is what you're going to see often. So fatigue, post-exertional malaise, orthostatic intolerance, often called POTS, which is one form, dysautonomia, heart inflammation, shortness of breath, brain fog, pain, all of those, and also meeting ME criteria, myalgic encephalitis. Sorry, my vocal cords don't collaborate at all on this word, so I'll keep saying ME. So this is just also a glimpse. So if we jump into the knowledge gaps, which was one of the questions, let's go first. I cannot pass over the first step, which we often forget, which is prevention of infection. There's no long COVID without infection. So this is still something very important to think about and educate about. We still need to avoid infection. We don't know what it looks like with reinfections, and we don't know for long COVID what it's going to be if multiple reinfections. So we still have to avoid infection. And when infected, there's some data which is still weak that rest during infection could reduce the risks of long COVID. It's not accessible to everyone, and the data is still not good. But this is a gap where we really have to gather information because it has huge implications for recommendations. I think this image tells for itself. There's decades of negligence of post-viral illnesses, and this is a chasm that has to be filled with knowledge in the future months and years. Long COVID is not unique. There's a lot of unexplained post-acute infection syndromes that we have a lot to do to work on to help people and to better understand, heal, and all sorts of things. So that's another gap. Post-exertional malaise, most people here probably know about it, but in case some don't know, is something that really has to be thought for healthcare professionals, but also to pretty much anyone. It's the delayed onset of exacerbation of symptoms following a previously tolerated effort. And it may last for hours, days, or even weeks, or even longer. And it's probably what is going to happen to most of the presenters today who are affected by long COVID with PEM, because the preparation or anything that you cannot pace through your day to make sure that you don't go over your threshold, and this is an image of it. So if you don't pace through your day properly, you often crash afterwards. And if you need an image, just think about your cell phone at 10%, and you have to walk through the whole day without it shutting off. And this is the whole envelope that you have. So on the research and clinical expertise gaps, there's PEM, which I just mentioned. We do need research, appropriate tools to screen and follow, knowledge transfer, and also for all forms of dysautonomia, which are not very well known in clinical care, but where there's also a lot of gaps in knowledge of mechanisms and treatments. So this is another gap that has to be filled, as is for all other post-infectious illnesses and associated conditions. And of course, we do have in Canada, there's a lot of data all over the world on long COVID, but we do lack Canadian data on all aspects of long COVID. So if I jump to healthcare services, just let you read those patients' words to catch my breath. But you can see it's not easy for anyone. There was this article we wrote a year ago, and Carrie, which is here today, and I wrote patients' perspectives on care of long COVID. It was a year ago, and still not much has been implemented concretely in most areas. So you can go and read, but it's still the asterisk madhouse. Current care in Canada is still unequitable in its availability and access. When primary care is accessible, it goes from appropriate support and care to complete gaslighting. Some provinces do have clinics or planning clinics, some we just don't know, but in everywhere it's still heterogeneous and insufficient. So most patients that have the chance to have a follow-up or specific targeted care is through research teams. They're very dedicated, but they're not meant to follow complex conditions in all their dimensions. So there's huge gaps in the whole care. And unfortunately, still this week, some research protocols unfortunately overlook current knowledge, which brings out potential harm under-recognized, especially in regards to PEM, post-exertional malaise, I mentioned earlier. We do need a safety net for every protocol studying long COVID and all post-infectious conditions. And of course, we need everything in care integrated in primary care. There's a lot of challenges even when you are in research and care. Chasms I mentioned. Also, many validated questionnaires are used but not interpreted in light of long COVID characteristics. And that's an issue. It's misleading often. It's also a source of gaslighting. So this is something we have to address. And there's not much clinical tools. We also need, and I address myself to all scientists and doctors, we need to revisit our perceptions. There's long-standing perception of normal testing being, for instance, psychosomatic. But lately, especially with multiple sclerosis, if you look at the story of this disease, you'll see that we do need to revisit our perceptions, and that normal routine testing doesn't equal psychosomatic. I don't want to undermine that psychosomatic disease exists, but we do have to understand that sometimes we just don't understand the underlying mechanisms. And there's a lot of research that's being done that we need to replicate and find out if they contribute to long COVID. There's a lot of pitfalls for patients, gaslighting, not even knowing long COVID exists while facing puzzling symptoms, PEM being under-recognized, which is a problem for evolution, which can actually is a risk factor for bad outcome. There's also a lack of access to care, treatment, and appropriate rehabilitation guidance. On the broader social impact side, few words again. And the one on top there, I went from thriving to surviving. It's really what a lot of us are facing. Sorry. So a wide range of symptoms calls for flexibility. The impairment can go from daily inconveniences to partial, episodic, or complete disabilities. And the insurance plans are not adapted for that. And also they sometimes last only 2 years, which is too early for long COVID to know how the outcome is going to end up. And there's a problem of acceptance and all the, the revisiting perceptions I mentioned. So there's a lot of problem in the coverage for disability in there too. And also there's a lot of holes in the disability coverage. Many have a net with big holes and many have no net. We do need to build excess and equity to disability coverage. Just a few words, lack of manpower. Long COVID might be part of explanation why we lack manpower and shortage of workers. And this is something that has impacts on economics. And also, if we go back to patients, navigating through the storm is very hard. Understanding disability plans, accessing resources and program is hard. Even for myself, university degree, and even when I was healthy. Now I've not even been down to this path. I just can't. And also important to know that disability does not only imply financial support, but also daily living aids and anything that could help function on a daily basis and improve quality of life. Also, family and relatives need information and support to be able to help properly and positively. So if we jump to the overall system support, things where actually I didn't know where to put. We are facing a situation now where there's no protection for the vulnerable population. And also most people still ignore they are vulnerable. They think it's only the immunocompromised or immunosuppressed, but it's a very wide array of the population with different risk factors that are vulnerable to COVID. And for the ones who know, they are on their own. There's no collective understandings of risks, transmission, and protection, and there's no help to protect. And also many long haulers, if not all, do now fall under the vulnerable category. Collaboration is also something that we have to improve. A lot of people are trying to reinvent the wheel in their corner. It's not easy to implement collaboration on a wide scale, but we need to do that. We don't have enough people to work on all that has to be done. We need to collaborate. So roll up our sleeves. Key messages, which I've used in other circumstances. It just comes up to complex conditions. Research needs to build on current knowledge. We need to transfer the knowledge. And we need to build a sustainable healthcare and appropriate support for all complex chronic conditions with collaboration. And remember that prevention is the utmost important. And we won't have time really. This was just a summarizing of pretty much all I've said applied to my condition. And you can see that a lot has changed.
Well, merci beaucoup, Anne. I think your unfortunate situation gives us a very unique physician as patient perspective, and for that, we're very grateful. Just for the sake of time, because I want to make sure that everybody has a chance to present, I'm not going to open the floor to questions or make any comments other than just to invite the next person up. So the next person to present will be Miss Carrie Anna McGinn. She is a patient advocate and a patient partner in research of long COVID and other complex chronic illnesses. Ms. McGinn, the floor is yours. I'm not sure if you're on mute.
Mute. Ha.
Perfect.
It always takes one at a conference and on a call. It's me today. All right. Well, hi, hello, everyone. I'm really glad to be here. I'm just going to set myself up here. All right. Great. Well, thank you. Merci beaucoup for inviting me to be here today. I am a health professional with a master's degree in community health and a background in health research and evaluation. And during the Christmas of 2020, I caught COVID-19. I missed out on celebrating the holiday with my 2-year-old because I was recovering in quarantine. My initial COVID-19 infection was not a walk in the park, but I wasn't hospitalized and I expected to fully recover. Well, fast forward 21 months later, and here I am, still sick, chronically ill, and quite likely permanently disabled. I live with long COVID, but that is not all. My acute infection also triggered other post-infectious illnesses and conditions. I now have myalgic encephalomyelitis, or ME, known to many by its previous stigmatizing name of chronic fatigue syndrome. ME is a chronic, complex, multi-system illness with no treatments and no cure at this time. COVID-19 also triggered a form of dysautonomia called POTS, or postural orthostatic tachycardia syndrome, that Anne touched on, and it also damaged my heart. So long COVID, ME, and POTS touch every aspect of my life. Just accomplishing the essential activities of daily living and parenting my small child use all my limited energy, and I cannot work. I now deal with dozens of incapacitating symptoms. I'm housebound, and I am an ambulatory wheelchair user. Since becoming ill, I have put my science background to good use and became a patient advocate and patient partner in research for long COVID and other complex chronic illnesses. I also co-founded Quebec's science-focused bilingual support group for people with long COVID. These experiences have given me a unique perspective on the needs of Canadians with long COVID and other post-infectious illnesses. Sadly, many Canadians still haven't heard about long COVID, and yet advocates have been warning about it since the early days of the pandemic. Myalgic encephalomyelitis, or ME, advocates predicted long COVID and were the first ones on the advocacy scene. These advocates were advising COVID-19 patients to stop, rest, pace, and warning governments of the mass disabling event ahead. They knew other viruses triggered post-infectious illnesses like ME. First waivers, who got long COVID early in the pandemic, also rang alarm bells, publishing the first patient-led study in May of 2020, which Hannah Wei will likely discuss later. Long COVID is one of many post-acute infection syndromes. Post-acute infection syndromes are not new. Dr. Akiko Iwasaki highlighted in her recent publication that viruses such as COVID-19 and other pathogens trigger post-infectious illnesses such as ME. So why are we looking at long COVID as though it is a brand new mysterious illness, when in fact it is part of a long history of post-acute infection syndromes? Recent research shows that at least half of people living with long COVID meet the diagnostic criteria for ME and POTS, illnesses which cause lifelong disability. So what is it like to live with long COVID? Well, it's been described by some of the more severe patients in our community as losing your life without dying. Just accomplishing the essential activities of daily living is beyond the capacity for many, including me. I am so ill, I can only shower once a week. And making meals for myself and my daughter is a chore that can take all day. We are parents struggling to meet both our children's needs and our own. Relationships are being tested and broken by the stress of chronic illness and disability. And we're losing our personal and our professional identities, our independence. We're being driven out of the workforce, with women bearing the brunt of it. In fact, 3 out of 4 people living with long COVID are women such as me, between 30 and 60 years of age. But we may be missing a lot of people because of lack of access to clinical care and research and systemic equity issues which are not being addressed. Alarm bells are sounding. People with long COVID and post-infectious illness, we are languishing in our homes and our beds. Or some that are still on the less severe end of their illness are being forced to push themselves when they should be resting and pacing. But we provide no supports to allow them to do so, causing them to push endlessly until the inevitable happens, which is that they get more sick and disabled than they ever needed to be. Many are without income, adequate income, and disability supports, such as disability insurance or access to the Canadian Pension Plan disability benefits. And the consequences are dire. People with long COVID and their families face food insecurity, they're forced to sell their homes, and are even becoming homeless. We're being gaslit by our healthcare providers, many of whom chalk up our illness to anxiety, mass hysteria, or psychosomatic causes, which the evidence shows is completely incorrect. So we need adapted, accessible, evidence-based care and biomedical treatments. Our healthcare providers lack knowledge and training on post-infectious illness, and many, despite well intentions, are still causing significant harm to patients. The few specialists and services that exist across the country already exceed capacity, and even the best in the field are only able to help patients learn to pace, manage key symptoms and comorbidities. And let's be clear, that's not enough, but at least it's a start. So we need to partner with and learn from the myalgic encephalomyelitis community. ME is a key piece of the long COVID puzzle. Over half of people with long COVID are currently and continue to meet the diagnostic criteria for ME, a chronic complex multi-system illness with no treatments and no cure at this time. ME has the lowest quality of life among chronic diseases and is one of the highest prevalences, even before long COVID. Some would have you believe that our long COVID community does not want to be connected to the history and science of previous post-infectious illnesses. I don't know where that narrative comes from, but that is not what we are seeing on the ground in Canada or internationally. We're seeing an enormous amount of collaboration between the long COVID and ME communities, working together toward collective goals. And it only takes a quick search of Twitter to see the scores of long COVID patients thanking the ME community for teaching them to stop, rest, pace, and providing support and guidance in the absence of access to clinical care. And yes, not everyone will develop ME, and we care about all of those impacted by long COVID in our community. But ME has unfortunately been a giant piece of the long COVID puzzle that just seems to not be discussed or addressed in Canada. And that's why I want to draw some attention to it today. Long COVID was a preventable tragedy. Would long COVID even exist right now if medicine had paid attention to previous post-infectious illnesses? Its research has been underfunded in Canada, and patients' needs have been ignored for decades. Going forward, ME must be an integral part of Canada's long COVID response. So now is the time to respond. We are asking the Canadian and provincial governments to invest in biomedical research and clinical trials, to better understand the underlying mechanisms of post-infectious illness, and to find a diagnostic biomarker and treatments for long COVID and ME, so that people such as myself may one day get out of our beds and back to our lives that we so desperately miss. We are also asking those in charge to improve clinical care through medical education and further investments. Post-infectious illness should be common knowledge, and knowledgeable and safe clinical care should be made available to all. There will be an increase in the number of Canadians living with disabilities due to long COVID. And it is necessary for our governments to strengthen disability supports, which are sorely inadequate, leaving Canadians in abject poverty. This could be achieved by increasing the number of weeks of EI sickness benefits, creating better access to the Canadian and the Quebec pension plan disability benefits, and implementing a universal basic income. So in conclusion, I want to thank you for inviting me to be here with you today. We are often asked as patients to share our stories, our experiences, even our grief and trauma. And while we're happy to do that, especially if it affects change for us and for others, it can also be incredibly frustrating to do it over and over again when nothing changes. So I hope those listening today will understand how much of my precious energy I've put into my presentation. How many of us are waiting, languishing in our beds, suffering financially, losing all that is near and dear to us. So please take my words and go on to demand and create action. Be the change that we need. And while today we're spending a lot of time talking about things that are not going well, I also just want to acknowledge that there's never been a better time to be more hopeful. Our wonderful scientists are collaborating on high quality research in partnership with the international post-infectious community and our patients. And with all this in place, there's never been a better time for post-infectious illness to be addressed effectively, not only for those with long COVID, but for all those who came before as well. So please feel free to reach out to me on email or Twitter.
Wonderful. Thank you so much, Ms. McGinn. I think your testimony was powerful, and some of the solutions you proposed are address some of those weaknesses that you so clearly highlighted. Thank you very much for that. I'd like to now ask Ms. Susie Goulding to come and present. Ms. Goulding is founder of COVID Long Haulers Canada, and she's the lead for Long COVID Kids, or LCK. She's the lead LCK representative for Canada. Ms. Goulding, I don't see you on my little Zoom panel, but
can you hear me?
Yeah, I can hear you. Oh, there you are. Hello. Great.
Yeah.
The floor is yours.
Thank you so much. I'm having big difficulties today with my brain function, and speaking always seems to be word finding, especially in concentration. So just bear with me. I also haven't had a lot of time. I'm involved in a PACER program out of the University of Calgary to become a patient researcher. And we had a large class last night, and I've been working all day. I'm a functional long hauler, but I've reached my maximum capacity for the day. So my brain is literally shutting down. So I'm also losing my voice. And I think I just wanted to make some points, as Carrie Anna and Dr. Bhéreur made some excellent speeches. I'm not blessed with the ability to public speak either. So I'm a very involved person in the long COVID community. I do also partner with research and do a lot of work recruiting out of our support group, trying to expedite the science and for researchers. So trying to, I'm known as a connector. So I think it's really important. Some of the points I made, I asked people in our support group, what are the barriers and what's missing? What needs to be done to help us? We feel like we've been just, left out to fend for on our own with really no supports. And so I've come up with a list. And so the first one that was on the list was the National Registry. Just to really understand the numbers, the count, the prevalence is just so important to know what we're dealing with, the size of the problem. Education, again, for doctors, for the medical communities, for workplace, for educational institutions. Everybody across the board needs to know about long COVID and what it is and how it affects people and their families. Doctors need education to recognize, be able to recognize long COVID symptoms and to be able to treat us properly. Think of a national list or network for doctors, our general practitioners, to turn to be able to, at a fingertip, be able to connect with specialists that they are, searching for, specialists that they don't know exist, for things that they have no information about, things that are caused by long COVID, the POTS, the dysautonomia, the conditions that we're dealing with, the post-exertional malaise, myalgic encephalomyelitis, POTS, PANS, everything that we're dealing with as long haulers. It's very difficult for doctors to point us in the proper care pathways when they don't know who they need to connect with. I think it's really important to create messaging, broad messaging, to destigmatize and normalize long COVID in a national messaging. There needs to be a different attitude with people when long COVID is and COVID is such a politicized virus that by default long COVID is skepticized and it's just not accepted, and it just needs to be messaged broadly. There are still people that frantically join our support group having no idea what is happening to them. having no idea what long COVID is, 2.5 years into this pandemic. They are frantic. They don't know. They've lost their families. They've lost their jobs. They've lost their lives, their livelihoods, all to an illness, a flu-like illness. So the messaging certainly needs to be changed. I think that was touched upon already, that we need to touch upon prevention. And really that the only way to not get long COVID is to not get COVID, and to bring back health measures, which is a really important message that I just can't imagine. My son woke up this morning, he said, "Mom, my throat feels funny again." And I'm like, "Are you kidding me? How is this going to affect my brain?" The second time I had it was in January, and luckily I had just been vaccinated, and it was okay. But people who aren't vaccinated, I'm due for a vaccine, and now here I am dealing with perhaps another COVID situation, which scares the crap out of me. I think another important thing right out of the gates is that mental health support needs to be talked about. There's basically no support for long haulers. I was lucky enough to be in a community wellness kind of group that had opened up and was taking long haulers, and it was a great program. And it went for two rounds. They did two different separate groups with different people, and then it got shut down. It was just getting going, and then the funding ended. So it was a really good support. People come to the group and they are suicidal. People, it's really crazy. You know, people have had long COVID for 2 years and they have been sick, and they don't know what they've had, and their doctor has said to them, "Well, I believe you have long COVID." And so, you know, it's unfair that people don't know the messaging. That's a point I forgot to make. It's unfair that people don't know what could potentially happen to you if you get long COVID. Mental illness needs to be addressed, a lifeline for people to reach out to. Far too many people are talking now about suicide and are discussing MAID. It's a common topic now, which is really sad. People who are dealing with COVID and don't know anything, and they've had it, they've reached the edge, they want to end it. And how is this possible? So that this is happening. Healthcare services, challenges. We need to be believed by doctors. There's still so much gaslighting that's happening. Again, I've just made random points here. Getting to and from appointments can cause us to crash for hours or days or a long time. And you know, people need taxis and taxi fare because don't have access to any benefits. ER departments are not screening for long COVID or any associated conditions. So there needs to be broad education. Doctors and healthcare workers are sick and are burned out, and they need support. They need more pay. There's a shortage of doctors, and there's 6 million Canadians don't have a family doctor. It takes a team of specialists working together to make a difference in a long hauler's life. So doctors have become a lot less available to us, which is really scary. There needs to be information available at the fingertips of our GPs. The symptoms we're having are complex. There are way too many for a 10-minute appointment. GPs need to schedule more time for our appointments. There needs to be a long COVID dedicated information network staffed that directs practitioners to these experts so that they can help us out. Something like a rocket doctor was discussed, available 24/7 walk-in clinic with testing and able to give referrals would be very useful to us, because many of us are visiting the hospital on many different occasions. I almost ended up in the hospital on Sunday. I thought I was having a stroke. I couldn't speak and it was really scary, but I didn't go because I just didn't want to wait for 10 hours. And if there was some kind of telehealth or something available that I could, or that people could talk about their symptoms and get quick referrals, it would really help. We're just really getting used to being ignored and told that we need to wait a year for imaging that we, is that my time?
No, please.
Okay. So there's a year's wait list to get an MRI. So the waiting periods are way too long. So now the broader social aspect, workplace accommodations, a guideline for employers that is continuously evolving on episodic illness, needs to be put in place so that workplaces have an idea of and of how to handle long haulers. Supports need to be put in place for employees to support long haulers, because in the end, we're going to end up costing them money, and they want us to get back to work fast. This was mentioned before also, that sometimes too quickly, that we end up crashing and we can't perform our duties, and then we end up getting fired because we're not performing up to par, and we're expected to do things that we're not capable of doing, which ends up hampering our recovery in the long run and is bad for everyone. People need to get rest and pace to recover. Many frontline workers, factory workers, people without benefits are working themselves into a slow, a fast downward spiral of chronic illness, getting better via resting and pacing. It shouldn't be a lottery, and it shouldn't be just for those who have a network of support or those who can pay for services. People are losing their jobs because they can't perform. They're losing their homes. Some people have no family and they have nowhere to go, living in cars. Sick leave doesn't work for long haulers because we're better for a few days, and upon return, we overdo it, then we crash, and then we get into trouble. People can work, people at work, like myself, use up all their energy to do so and crash at the end of the day, unable to do anything else. No cooking, no cleaning, no social time with family. I'm sometimes in bed by 7 p.m. Actually, mostly I'm in bed by 7 p.m. I haven't been able to cook a meal since June. I get home from work. I don't walk my dogs. I don't help my child. I don't do a lot of things that I need to do. And I have a lot more that I need to get through, but practical community supports are just so important. And I would love for someone to, because I have a whole list of things that could be implemented and that we need. And also, I just need to mention kids. Kids need support too, especially with school and with tutoring, with families understanding their situations. And again, just 7 minutes is just not enough time, but thank you very much.
Well, Ms. Goulding, I think despite your, you're battling the exhaustion and asthenia that you've had to deal with, especially over the last few days, I think your insights have been very eye-opening. Thank you very much. If you have additional points to make, please don't hesitate to send it into our secretariat, and they'll be, integrated into the documents. Just for the sake of time, we will move on, but thank you very much on behalf of the committee. I'd like to invite next Ms. Cara Kaup. She is a pediatric physical therapist and also peer support co-director, a member of the executive board for long COVID physio out in Alberta. Ms. Kaup, the floor is yours. Ms. Goulding, perhaps if you can stop sharing and maybe that'll help.
Sorry, I was on mute. You can hear me there now?
Yes, we can hear you. Thank you.
Okay. Yeah, sorry about that.
So as the previous speakers have said, they've covered a lot of the points I think that are sensitive for most of us with long COVID. I got sick in the very beginning of the pandemic in early March of 2020. My primary symptoms were sore throat, headaches, a low-grade fever, and this weird intermittent chest tightness that I couldn't sort of describe how it was affecting me. It was very random in the beginning. And then I progressed and got much sicker a few months later, felt like I had a heart attack a number of times. Unfortunately, I never tested positive for COVID, even though I had a confirmed exposure with somebody who had more classic symptoms and lost their sense of taste and smell. I eventually went on to be diagnosed with POTS, dysautonomia, and long COVID 14 months into my illness. And then most recently in May, I was diagnosed with ME/CFS. So it sounds like I have a lot of similarity with the previous speakers. I too get voice fatigue when I really overdo things. Post-exertional symptom exacerbation is one of my biggest problems. And so I know I have chest pain every day. I have headaches every day. But my voice fatigues if I do too much, and my low-grade fever returns. And yeah, post-exertional symptom exacerbation is just a constellation of a whole bunch of different symptoms. It's much more than being just tired. Cognitively, I think sometimes I don't give enough credit to how I'm impacted. I'm pretty lucky. I can read a fair bit. I can, watch shows on TV, that sort of thing. But when I do things that require a fair amount of cognitive load, it definitely increases my headaches and my chest pain. So Hannah, you were involved with us as well. We did a long COVID physio forum presentation last weekend. It was an international forum for people from all over the world. And we wanted to bring the lived experience to healthcare providers and to people living with long COVID. And I can tell you, all of us were paying for it all last week. It was worth it, and I'm glad we did it, but I definitely paid for it. So I think it's really important to make sure that healthcare providers are getting educated about post-exertional symptom exacerbation, because that is a really big issue for us. And as the previous speaker said, a lot of us are being diagnosed with ME/CFS. Post-viral illness is not a new thing. We need to learn from our previous ME/CFS colleagues and other post-viral syndromes, and we need to build on that knowledge that they've got. I mean, I'm a physical therapist. Exercise is what I've been trained to do for years and years and years, and I had never heard of stop, rest, and pace. I naively didn't know very much about post-viral illness until I was living it myself. And the stop, rest, and pace is so important. In the beginning, I was still jogging. I was still walking 5 kilometers every day. I was still pushing. My cardiologist thought I had viral pericarditis and, was encouraging me to walk every day, but walking on a treadmill every day for 4 months put me in bed for 4.5 months, and I ended up being bedbound. So some of the main messages to get out there is post-exertional symptom exacerbation is real. Graded exercise therapy can be very damaging to a lot of us. I wonder if I actually would have progressed and become as sick as I was if I had just rested in those first couple of months when I was ill, rather than trying to continue to push it. And it's really difficult because you can't trust your body. You can't, when you're doing things, you can't push through things anymore like you used to. I'd be a little bit tired, but I would still push to do something. And you just can't do that anymore. And you really, my day consists of getting up and having my cup of chicken broth and having my, 500 mils of electrolyte water and having my salty oatmeal and, then doing my laying down supine exercises and doing my recumbent biking. all of those things to try and quell the symptoms of POTS and dysautonomia. And so it's a really difficult dynamic and episodic disability, and it's hard to wrap your head around how to take care of it. I had written down a few notes here, but the ladies have covered a lot. But one thing that really struck me at our conference last weekend is one speaker was saying if he extrapolated some of the data, that 1% of the world population could become disabled with long COVID every year. And I think it's really important for Canada as a nation and other countries to get the word and the education out there. Long COVID exists. I mean, everybody around me, COVID's over, nobody's masking. I'm the only one masked whenever I go anywhere. And, when the country or when the province is listing how many people have died from COVID, like we need to list how many people have long COVID and how many people's lives have changed significantly. Oh, sorry, that's my medication alarm. Time to take my beta blocker. Forgot to turn that off. So anyways, so many people's lives have changed. And so I think the really important points, I'll just try and look on my notes here because much has been covered, but healthcare providers need to be educated. We need to figure out a way to educate all the family physicians because unfortunately they're carrying a large load of the people going to them. And family physicians should be able to diagnose POTS. You shouldn't have to wait 10, 12 months to get into the autonomic lab to get a tilt table test. Like you can just do the laying down, standing up, taking your blood pressure, or the lean test, the standing test to figure out, that you have this orthostatic intolerance. They could be prescribing the beta blockers for you. I waited months and months to be seen. And if I could have got treatment much sooner, then maybe I wouldn't be as sick as I am. And I think that we need to realize that we just don't have the right tests yet. Lots of tests come back normal, but we just don't have the right tests yet. We're not normal though, for sure. Our autonomic nervous systems are totally messed up. And, it's looking more and more likely that this is a vascular disease, that we've got vasculitis in some form. Like I started feeling a little bit better in the summer, and amazingly on my iWatch, I'm not desaturating nearly as much as I used to. I used to desaturate 14 out of 30 days. And in July, it only happened 4 days. In August, it only happened 5 days. So to me, there's, I'm not sure about the validity of, the iWatch, but it definitely struck a chord with me that, my body is not processing the oxygen well. Dr. Patino made a really good point in the conference last week, talking about how we are boats with so many anchors, and we have so many different issues that are going on with us. And it's really difficult when you go in to see your family physician and you've only got 10 to 15 minutes. So you kind of have to prioritize and pick your most important issues that you want to discuss for that day because, they've got a ton of patients to see and they don't have the time to spend with you. And so I really, really feel, and I've been pushing in my province of Alberta, and I think that our province has been trying to address things, is we need multidisciplinary clinics with people who know about post-viral illness, who know about MECFS, who know about PEM and PESI, and who have physios and OTs and psychologists and social works that can help you with all the different implications of the disease. When you talk about the broader social impacts. So I haven't been able to work for 2.5 years, and I'm faced with being terminated next month, in November, if I can't return to work. So I'm going to try a very slow return to work in October at 3 hours for once a week for a couple of weeks. And I'm not sure how my body's going to respond. And it's really scary, to wonder, have I lost my role as a physical therapist? Am I going to be able to work again? Am I going to be able to do patient care again? Financially, I'm privileged. I have a spouse who has another income, so I still have a roof over my head, but what's happening to all the single parents out there or the families where they're the primary breadwinner? There's so many different implications. And then on the family dynamics, I have 2 younger adult children, and it was really hard for them because they wanted to be socializing with their friends, and I didn't want to have anybody in the house. I was so scared of getting sick again. I just thought my heart couldn't take it, and I thought I would die if I got COVID again. So that caused for lots of stress when they were in their later high school and early university life and wanting to do some of the normal things that many of us got to experience. And my recreation was all about physical activity. I hiked, I biked, I swam, I did Pilates, I skied, and now I can't do any of that. And so that's been really difficult, but it's also been difficult for my husband because he's lost his activity partner and he feels guilty if he's still going to do the activity. And I can't, and I want him to do that, but it's a lot of, you need to have a lot of communication in your marriage and in your family about all the different dynamics of how it impacts us. And I think lastly, I would just say that we really need to focus on trying to get these multidisciplinary clinics going, developing that expertise, then translating that knowledge out to all of the different community providers, train all of the providers in community and in hospital to start screening people for long COVID in any area that they're working with them, and knowing, the correct treatment strategies or the things that have worked. And we really, being a pediatric therapist, we really need to get something in place for kids across Canada. I mean, at least we have some things going for adults, but there's so little for kids. And so I would really push that we continue to try and set up multidisciplinary clinics for kids as well as adults. And I'm going to stop there because I'm well over my 7 minutes. So.
Well, Ms. Kaup, I think thank you very much for sharing your ordeal and hearing about your diagnostic odyssey, the suboptimal evaluation and management steps that you had to go through. Again, it's very enlightening for us. We also have another group of panelists, and I'm going to pass the floor over now to Dr. Cheung, our co-moderator, to lead that discussion.
So thank you very much for all those who shared. Because I really would like to have some time for questions from the task force members and also from the audience as well. I'm going to ask that the next 4 folks to try to keep to that 5, max of 7 minutes. I think, many things are shared sort of by the prior presenters. So if you can, we want to hear sort of like, what is it for you with lived experience and what to add to this sort of conversation. So I know it's a hard task, but I would like to give an opportunity for the task force members to ask questions as well. So my next up is Hannah Wei. So Hannah is a long COVID patient researcher and is the co-lead of Patient-Led Research Collaborative. Hannah, the floor is yours.
Thank you, Angela, for the introduction. Hi, everyone. I'm really honored to be here, and I'm really honored to be among a lot of you who have spoken before me and described to the T the long COVID experience. Before getting long COVID, I was a semi-competitive martial artist. I traveled to Southeast Asia almost every winter to train in Muay Thai, and I fought there. And in my career, I was a traveling field researcher with international clients in Asia and Africa. So I had a great career. I had a really great, vibrant life before getting COVID. And when that event happened in March 2020, my reality completely changed. I was suddenly bedbound. I was chugging medication. And what was happening to my identity was that I wasn't able to find support in my current network anymore. I no longer was able to relate to people who were, out there still doing what they are doing. So, learning about my symptoms, learning about post-viral illness, and trying to reconcile what I was hearing in the patient communities and what's being said in doctors' offices and in media, something just did not click with me. And so that led me to co-found the Patient-Led Research Collaborative. And honestly, looking back, this was kind of a coping mechanism for me. So I'm going to share some slides about what we've done at the Patient-Led Research Collaborative and kind of add on to the evidence and the recommendations that everybody else has presented. Let's see if this works. Great. Okay. Is everybody able to see this? Great. So I think one of the things that I really want to hone in on is the impact of long COVID on people's work identity and people's ability to work. Because as the pandemic and the long COVID situation drags on, as the previous speaker has already mentioned, there's people need to make a living and people need to continue to find ways to survive. Long COVID has had a really notable impact on work participation, but little is known about this experience from the perspective of patients, and little is known about what we need to continue to work. So my team set out to do some mixed methods research around this, and this is unpublished data right now, but we are writing papers and we're trying to get this out as fast as possible. Within our cohort of about 5,000 long COVID patients, and this is recruited by online surveys and via our long COVID community at Body Politic, 45% of people said they needed a reduced work schedule and 20% required work leave. So we, as I said, we did a mixed methods online survey. We captured symptoms and trajectories and personal experiences, and this is including Canadians as well. Going back to where we began, so the Patient-Led Research Collaborative, we are a group of patient researchers, and we've all been in this situation where we were confronting our own work realities. And one of the greatest things about working with this group is that we have a lifetime of career experiences to bring to the group. And I think one of the misconceptions when I talk to other researchers or other teams is that, there's this big divide between what patients should know and what quote unquote experts know. And I think our team is a direct example of why this misconception is wrong. And going forward, we really need to collaborate with patients to take in the interdisciplinary expertise, especially since more and more people are going to end up with long COVID and are going to have to find ways to contribute despite having long COVID. And so these people's expertise should be respected. Some of the primary themes that we found when we did this research, we asked people about their experiences going back to work and trying to find ways to adapt to work after long COVID. We found that people have a strong desire to continue to work. This quote underneath just really outlines how I feel as well, regards to my career and still being able to contribute. People expressed, very strong need for having support, both at work and at home. And I know this is mentioned already. People face a lot of stigma going back to work, and sometimes this comes from ableism, not understanding that post-viral illness is a thing, and some really nasty stuff that we've heard people face, such as colleagues fearing that they're still infectious. And I think throughout all the presentations, we've heard quite a lot about the post-exertional malaise or post-exertional symptom exacerbation. This shows up at work, and this can be very dangerous when employers and workers are not aware that there's this force at play. especially when people first return to work. I'll just skip right through. So going back to our other paper, we found some patterns in terms of how people experience their symptoms. And this ties right back to how they experience work. There is a very big misconception still that, long COVID kind of tapers off and goes away in time. And we did research on over 200 symptoms, and we did some clustering by temporal similarities, so how they show up over time. And we see that, there's some symptoms that do go away in time, and in fact are very dominant in the beginning, like the first cluster, runny nose, sore throat. You get those in day 3, day 4. Cluster 2 are the symptoms that kind of exacerbate a little in month 2 and come back and forth, and sometimes they taper off. But cluster 3 is the more chronic symptoms, and this leads right into folks who end up getting ME/CFS diagnosis. And this one is the one that I think, people who are going back to work, people who are trying to seek long-term support are facing the greatest difficulties. Now, I think what I want to contribute to our discussion going forward, and what I think, that the task force can really take away from our knowledge, and feel free to ping me afterwards for the 20 or so slides that I omitted for this talk, is really understanding we need to shift our focus from recovery expectations being linear to something that's more cyclic, something that's more dynamic. And this also bleeds into how we treat people at work as well. So we think that there needs to be a non-linear process for all COVID positive employees going back to work, whereby folks don't necessarily need a documentation to access support and benefits. As folks have mentioned before, not getting a positive test result was very common, especially in the beginning. There needs to be a discussion of a recovery process and accommodations, regardless of current symptoms. You could be showing up to work, or you could be showing up to presentation like I am right now, having a low symptom day, but this might not be true next week, or this might not be true after giving this presentation. I might crash. And so taking only a slice in time and using that as judgment of somebody's recovery process is very misguided. So having a repeat discussion of supports and accommodations is needed at certain points in time. And so going forward, I think we need a better understanding of long COVID as a cyclic, as a recurrent, as an episodic disability framework, and understanding how that applies to people who are trying to find support and financial support as well. To keep this short, thank you very much. Please reach out to my team or myself if you would like more information on what we're working on. As I mentioned before, this is a paper that we're really excited to write. And also, I would also like to thank, the folks who are on this panel whose faces are very familiar. I see Kelly, I see Angela, Carrie Anna. It's really great to be among folks who are very passionate and dedicated to helping everybody get through this pandemic with long COVID. Thank you so much.
Thank you, Hannah. In view of time, I'm going to go next to Adriana Patino, representing Long COVID Canada. Adriana?
Hi, sorry, I'm just trying to. Thank you very much for having me here. It means a lot to giving us a voice to the people who are suffering through this horrible condition. This is not just creating media awareness. This is actually in hopes, a lot of us, obviously, like it's been mentioned before, know that it's probably going to destroy us for a few hours or the next couple of days, but it's in hope that our information and insight actually creates change in not only the community, but in the overall spectrum of the system, and from an individual level to a healthcare level to mental support and workplace level, which are all impacted in different ways. So first of all, I want to apologize. I also do have neurological issues, and I'm gonna try to avoid what has been said already and avoid repeating the notes. But I think I just want to mention that the fact that it's been mentioned literally so many points, everyone is talking about the same points, highlights the importance that we realize this is what matters, this is the impact, and all of us who are suffering this to see what needs to be done. After 2 years that the people who should be taking care of us for not to realize these issues when we are very clear what we're suffering and what needs to be done, I think it's really crucial to identify that these are in fact very serious and impactful issues happening in our communities. So first and foremost, on the knowledge gaps, as it's been acknowledged, this very huge issue of long COVID, it needs to be recognized for the complexity that it is. It can't be categorized under anything already existing. It does have a lot of similarities with other conditions, like it's been mentioned, such as ME, CFS, MS, and so on, but it's its own unique puzzle. And when you get sick with COVID, whether you have a mild infection, you get hospitalized, you're asymptomatic, it's a roll of the dice. You know, you don't know what kind of condition you're going to get, if any. You don't know what kind of thing you're going to develop right away. You don't know what kind of things you're going to be developed throughout time. For my own personal story, I got infected in Christmas 2020 as well. I've took every single precaution possible. I still don't understand how I got sick. I woke up on Christmas feeling absolutely like the energy was sucked out of me. My chest was an elephant sitting on me. I could not breathe. I was weak. I was shivering. And I used to be a very high level competitive swimmer before. So to have my lungs and the inability to breathe that bad, it was really desperation to me. I had a lot of heart pain, like actual pain in my heart. My heart rate would go to 160 laying down for absolutely no reason, not even standing up. And not even to comprehend, my brain fog was really bad. I went through cycles of feeling like I was gonna die in the middle of the night out of suffocation because I could not breathe. And I was in the ER at least twice a week because I was feeling like I was gonna die. And for the ER staff to tell me, oh, it's just COVID, just have some chicken soup and rest, even though I made it, with pictures of my oxygen being anywhere between 79 and 92. If I was at 92, I was incredibly grateful for the breathing, being able to breathe better. But having that suffocation and having people tell you it's nothing when you're about to die. And it was later on discovered that I've had several mini heart attacks as well because of the lack of oxygen, that I was in hypoxia for so long. It actually created even more damage to my heart. There's a part of my heart now that is not working properly. I was incredibly lucky to find a new family physician who had just moved from the States. When I first approached my family doctor of 20 plus years, she told me that after having a Holter monitor and showing my heart rate going to 180 for absolutely no reason, and palpitations and me fainting when I was getting up and all of that, she told me that I had heartburn and anxiety. And my new family physician, when he checked my lungs and I told him the story of my previous family doctor. He was so upset to learn that I was dismissed like that. And unfortunately, that's a story that many of us face. We are dismissed, we are being gaslit, we are being thrown under the rug, or you're exaggerating, you're this, you're that. It's not true. Thankfully, my new family doctor checked my lungs, and he told me that my lung damage was even worse than someone with asthma and pneumonia combined. And thankfully, because I was a swimmer, I was alive. It was my swimming lungs and my swimming fitness that was keeping me alive. And when I joined Long COVID Canada for support, and I realized the amount of people who are going through the same thing, people who are suffering, people who go through the first initial shock of what on earth is happening to my body. I used to be young, I used to be active, I used to be healthy, I had perfect diet, you know, I rarely got sick, and now I'm developing all these conditions that I have absolutely no idea where they're coming from. And the confusion, the feeling of abandonment, you're fighting against your own body, you're fighting against your own mind, you're fighting against your loved ones who don't believe you, you're fighting against your doctors, you're fighting against the system, you're fighting against your work. It's a constant fight that absolutely eats you from the inside out. Feeling trapped in your own body, feeling trapped in your own mind. When I have my neurological episodes, you know, I can't read. I used to love reading. I can't read books anymore because I can't grasp the idea. I can't follow a paragraph. I can't follow complex movies that I used to love. I can't follow complex conversations. I can't have multiple people talking in a room. I can't have visitors because my brain just short circuits and I stop understanding words. Sometimes I want to say something and words don't come out of my mouth and I feel like I'm having a stroke, but I've gotten so used to it. And that's what is so bewildering, that things that used to send me to the ER before, now is something normal to me. I suffer from heart pain on the daily, and now I know I just need to breathe, scream, cry, punch, whatever, just try to not think negatively and just let it pass. And sometimes it's such a pain that it lasts for hours, that I'm screaming out loud and there's nothing that no one can do. I can't go to the hospital because they tell me that there's nothing they can do. And to see that in not only on myself, but on everyone in Long COVID Canada, to experience that, especially too now that everything is lifted, all preventive measures are lifted. People have previously gotten infected before and recovered fine, and now they're infected again and they're developing long COVID and they're not understanding why, because the message hasn't been put out there that it's always been, you either die or are hospitalized or you recover and you're fine. No one has talked about the gray hell area that a bunch of us are trapped, that a bunch of us have, for our own purposes, trying to understand this confusion, have researched specialists all over the world. What is this? What has been coming out of this? Who's studying this? And to see that people out there still 2 years into this pandemic say, long COVID is probably not an issue. It's not an issue so important enough for the government to take notice. No, it is a huge issue. It is a huge issue because in our group, at least, 83% of the members are women. The majority of that, the number one age group affected are between the ages of 35 to 44, which is prime workforce ages. Second place, tied with, there's two age groups tied for second place. It's 24 to 35 to 34 and 45 to 54. So that is the prime age that people are starting to either become effectively contribute contribution to society in the workforce, they are starting to build up their financial status. They're starting to become financially independent, and you're taking and having that freedom taken away from you, having everything that you've worked for your life being taken away like that because you had no idea that this could happen to you. And not to mention the risk that when your options are you die and you're hospitalized, you can become permanently disabled or at least have a condition that is at least affect your quality of life, or you recover well. When 2 out of the 3 options are not positive for you, I think people would have more conscience in getting infected and would take more personal responsibility in taking care of themselves, because the message would be out there. It would still be on them, whether they take care of themselves or not, but at least you're being transparent of this is what could happen to you. You could very well lose everything that you've worked your entire life. And it's not only affecting you, it's affecting your interrelationships, your marriage, your loved ones, your family, your friends. There's a lot of people who don't even acknowledge that they have long COVID out of fear of being made fun of. Why is it acceptable to make fun of people with chronic illnesses because they look healthy? Since when is that acceptable? And I know that has been happening for years, but not to minimize all the other chronic conditions, but this is becoming a massive event. And I've spoken enough, and I'm sorry.
Thank you. Appreciate that you shared with us about sort of, you know, what other patients and your experiences as well. We do appreciate that. I'm going to go to Manali Mukherjee and Sarah Butson after that, but I am very aware that it's 5:30. I really would like the task force members to ask questions. So, and I see already several in the chat as well. So can I pass it to Manali Mukherjee, who's an assistant professor of medicine, Division of Respirology at McMaster University, and affiliate scientist at the Research Institute at St. Joe's Hamilton. Manali?
Thank you so much, Angela, and thank you so much for inviting me to this task force discussion today, not as a researcher, but somebody who has lived experience. And, you know, listening to everybody for the last 1.5 hours, and particularly being a very, very long strenuous day, it's wearing off, because suddenly I feel like I lived my whole last 20 months. So just shortly, I got infected in January 2021, 7 days before I was slotted to get my first vaccine. And it was absolutely because some people don't follow protocol, and how much ever I took care of myself and kept myself in a bubble and my loved ones in a bubble, we all got infected. And it was me who ended up having terrible symptoms, to the point that I was bedridden, fatigued, headaches. I would end up reading 15 publications over a weekend. I'm sure Angela and every other researcher here understands that. Sometimes I could even do 15 in an evening. Now I struggle with even one and then remembering it. There was a time, there was a joke at our university at Firestone, where I'm based, that Manali reads papers for bedtime stories. She reads PubMed for bedtime stories, because I would be able to reach out right and get you papers, the names, when the study was done, what year it was done, which university it was done. And believe you me, I can't do that anymore. And it's all the last 1 year, whatever papers have come out, whether it's in the area I'm working on, whether it's long COVID that I'm so interested in, because not just for my personal experience, because of the research that is ongoing. It's becoming extremely tough for me. And brain fog is an issue, but people don't believe you. So I hear each and every one of you on this panel who have spoken so far. It is definitely a problem, and especially when you look healthy, you behave healthy, and you're young. It's something that people don't believe. Now, one of the plus points that I had, one of the privileges that I had the training in immunology. So as soon as I started feeling wary, and as soon as I started feeling the symptoms, and because I'd already been following COVID, the clinical trajectory of the disease itself, right when it started, I was already a little bit worried about possible post-viral syndrome, having also worked on Guillain-Barré the year before coming to Canada. So something like this could happen was a possibility in my head, because I'm trained in researching autoimmune diseases, a possibility of those kind of immunological aberrations where the body actually goes against you. So if you hear what Adriana just said, if you hear what Ms. McGinn just said, you can hear they're all talking about how you feel like your body is not your own. I mean, that is basically your immune system not being with you. So that's the reason why we started even working on it. And then I got COVID, and then I felt sick, and then we got some money to do the work. So maybe I could write that grant because I could empathize. And then I got in touch with Susie Goulding here, and I started hearing all the stories. And, for the last 1 year, September 2021 is when we had our first patient recruited in our long COVID study that looks specifically for rheumatological complications. Since then, till today, we have had 85 patients, and I feel like I've relived my first 12 months of long COVID again and again and again. And then I got reinfected again, and I got a little bit better, but I feel like I might have a relapse any day again. And it's that fear. I don't want to go back to that place again. So coming to the knowledge gaps, having all that in perspective of what has been said so far and the lived experiences, and my one edge, the fact that I have a background in immunology, I look at the knowledge gaps this way. It is never wrong to know fundamental mechanisms. We need more research on fundamental mechanisms. The COVID pandemic and the long COVID thereafter, the aftermath of pandemic, that's how I look at it, has showed us the importance of doing bedside to bench and bringing it back to bedside research. It's how important collaborations have become between clinicians, scientists, and patients. We need to hear each other out so that we can find the clinical questions, the gaping holes, and opportunities, and do the work together and help each other out. The next thing, which I have been continuously, which has been coming to me because I've been trying to look at all the patients who are being recruited in my study. I have every week discussion with the clinicians who are involved in the study, with the rheumatologist who is involved in the study, and we are having discussions. And some of the questions that are very, very pertinent, and unfortunately, we do not have the resource or the money to look at that, to study that. For example, how does long COVID symptoms vary with the acute phase severity? Because many of the acute phase patients got treated with dexamethasone, got treated with tocilizumab. Some people didn't get treated at all. Then how does it vary with once you've had vaccination, 1 vaccination, 2 vaccination, booster, types of vaccination? Because there has been a lot of studies showing VIT and different type of post-vaccination immunological issues too. So how does that affect? Does vaccination help? Does it not help? Do reinfections affect long COVID? I'm hearing stories from patients and lived experiences from various people, how how getting reinfected has suddenly brought in a relapse because they were going through a remission fine. Adriana just talked about that. They did not get long COVID from the first infection, but got it from the second one. Me, myself, after I got reinfected in March, I actually got better for 3-4 months. I actually got better. Now I'm thinking twice about what if I get reinfected again, and what will happen if I do. The next knowledge gap that I really think it's so important is, why do some individuals develop cardiac issues while some develop post-exertional malaise, while some develop lupus-like symptoms, while some recover? So, and how do we prevent it? How do we treat them? Is there a possibility to get an early prevention, early treatment marker? Do we have to reinvent the wheel of finding a therapeutic treatment? I don't think so. There is enough evidence out that there is post-viral syndromes, and at least I'm looking at autoimmune diseases. So maybe we can just see, speak to our rheumatology colleagues, speak to our cardiology colleagues, speak to our neuroimmune colleagues, and see what can be used, how it can be used, and use some sort of an adaptive trial, and then put biomarkers in place to assess treatment response. And my last thing that I would like to talk about, everything that you want to do, the knowledge gap, it will not be it will not work unless we see the system, then assess the system, and then see the system again. So longitudinal studies are extremely important. All the 85 patients were, as of today, 85 patients were in my study. I will have 120 patients by the end of, by the start of October. I have funding only to look at post 6 months. What about those patients after 2 years? Would they get a relapse? What if they get another infection, another one, any other? What would happen to, would they get a relapse? You know, since anyway, physicians like primary care physicians are not so wary, what happens to them? So I will leave with that thought. I think there is a much importance on funding requirement to do longitudinal studies, more mechanistic study, more collaboration, patient education, physician education, and free flow of thought process and talks. Seminars like this should be more often. Thank you.
Thank you, Manali. I have been monitoring the chat as well, and lots of good points in the chat. And thank you for those who have put important points in the chat. I can tell you that CanCOVID will keep track of those. And let's go to our last speaker so that we can open up for questions. So our last speaker is Sarah Butson, from Public Affairs and Policy Analyst of the Canadian Lung Association. And Sarah will speak from to the CLA perspective broadly on long COVID and what they're doing as well. Sarah?
Thanks so much, and thanks for having me. So I represent the Canadian Lung Association. I'm not here able to provide lived experience, but I will start by saying it's been such a privilege to hear everyone's stories today, and it is deeply impactful, and I've certainly learned a lot. So for those of you who don't know the Canadian Lung Association, we are one of the oldest health charities. We were developed on the backs of another pandemic, TB, and fast forward 122 years, and breathing has never been more important. So we are a patient-focused organization. We represent the 1 in 5 who suffer from lung disease, as well as their caregivers. But we also represent the 5 in 5 who simply need to breathe. So really, we represent the full spectrum of lung health. In light of the timing, I've been slashing my statement, so I encourage folks to visit our website to hear any of the specific respiratory and lung health symptoms, but many of them have been highlighted more accurately through the narrative we've heard today. What I would like to share briefly is a lived experience into our own narrative through the story of a young Canadian named Joyce. Joyce was 30 when she had a suspected case of COVID-19 in March of 2020. An entrepreneur, healthcare advocate, avid traveler. She was abroad when she became sick. Similar to others, she was not officially diagnosed with COVID-19 at the time due to limitations of testing, but her symptoms were linked to COVID. Among her symptoms were extreme fatigue, dry cough, sore throat, chest pain, and similar to others, she described the chest pain as though someone was sitting on her chest. So while most of Joyce's symptoms faded fairly quickly, the cough and chest pain persisted. She sought help from her family doctor, was referred to a respirologist, and ultimately was treated as a suspected case of long COVID. She went through a series of tests, including chest x-rays, pulmonary function tests, to determine the cause of her chronic cough and pain. And she describes that the most difficult part of the experience for me was dealing with the uncertainty. It's hard not to think the worst when you have chest pain. And since so little is known about long COVID, it's been a journey to understand the cause of my symptoms and the prognosis. So Joyce's story, I think, really hits home and reiterates what we've heard from other speakers on this panel. And, we can only imagine how complicated this becomes within the lens of lung disease as folks are trying to figure out how this interacts or complicates their existing lung disease symptoms. So one of the questions that was asked today was around the knowledge gaps, and I think my fellow panelists have already highlighted most of them, but I'll reiterate that, long COVID is still poorly defined in terms of its symptoms and its patient profiles. The landscape of COVID and long COVID is ever evolving, and so requires responsive and progressive approaches to research and support. There is a need for broader education amongst both both the public and the healthcare providers alike. And importantly, we need to get a better sense of the best types of services, programs, and supports that are going to be most helpful in relieving these symptoms and when and where to deliver these. So we are also investing in helping to address some of these knowledge gaps. We are currently supporting 4 Canadian researchers who are working on the respiratory health effects of long COVID, and this is through research co-founded by ICRH. Some of these highlights include the identification of a blood-based biomarker associated with long COVID patients who experience shortness of breath. We have a co-creation of an algorithm to generate a provincial level data set of patients. Other research related to the identification of subpopulations and the average duration of symptoms. And more of these details can be found online as well. So we've started to learn a lot more, but yet, still gaps persist. And I think the final question that was related to the system support, and that's, where sort of our files work from a public affairs perspective, in terms of what needs to be done at all levels of government. Last year, our organization really opened our eyes to this issue. And at that time, we saw a huge gap in terms of our understanding of what long COVID was and who it affected. And so there was a real need for research. And so we, amongst others, we're calling for research on long COVID funding. And so we've been pleased to see some of those commitments. Federally, we've seen 20 million over 5 years, and that's a good start. But as we've heard today, folks who are experiencing long COVID symptoms really do need support today as well. And so the Lung Association is calling for a national long COVID strategy that would include substantial investments in research, a national long COVID registry, and then support for interdisciplinary rehabilitation clinics across the country. So I'll just end by saying that post-COVID deserves attention. And in moving forward, we need a multifaceted and evolving approach that includes prevention, collaboration, management, support, innovation, and supportive policies. So again, I'd really like to thank you for the opportunity for having spoken today, and I'd invite anyone to reach out to the Canadian Lung Association for collaboration and support.
Thank you. Thank you so much, Sarah, for joining us today. In view of time, I really would like to have the task force members ask questions. And I'm going to go to Doug Gross for the first one.
And thanks to all the panelists for speaking today, sharing your experiences. Given the wide variety of experiences that we have heard, I kept thinking back to Anne's her topic of, or talking about the holes in our safety net. So my question, I posted in the chat earlier, I was just wondering what's the most effective way to fill these holes? What resources or public supports are most needed?
You can raise your hand in terms of responding.
Doug, I think your question was addressed to Anne, right? Or
no, it was Anne got me thinking about it. So it's to all the panelists.
So Carrie, go ahead.
Thank you. Well, I think one of the most important things is that our experience shouldn't be left up to luck. A lot of us are lucky. We had a doctor who listened to us or didn't. We might have had care pathways that our province worked out on or didn't. So I think there needs to be coordinated care and defined care pathways that are not reliant on just the luck of the draw of when you got COVID. I think, for example, of medical education being a really big part of it as well, of filling those holes, because when our medical practitioners will really recognize COVID, and they'll be able to help patients understand what's happening to them, and they'll be able to help patients access, for example, disability supports. We will be able to therefore fill in some of the gaps that we're facing. And of course we need, as I called for in my presentation, like we definitely need, just give me 1 second. We definitely need to strengthen disability supports in terms of like EI sickness benefits. There's really a gap. What happens to people is that they have 15 weeks of EI, and then after that, there's nothing. absolutely nothing until they may, in a few years, if they're lucky, access CPPD or QPPD, which is the Canadian or Quebec pension plan disability benefits. In between the two, there's nothing. And so people are selling their homes, living in their cars. And so we really need to address this inequity, which has existed before COVID, which it's just that the pandemic is highlighting it. We need to think about universal benefits. So I think I will leave it at that.
Thanks, Ms. McGinn. And then I think on the panel, I see going left to right, I see Ms. Goulding, you have your hand up. You want to make a comment or an answer?
Hi. Yes, I just wanted to say that community support programs at a community level are so important to help people rest and manage their symptoms. Single moms, children who have long COVID, supports for parents, for kids, for school, things like, I don't know how, but cooking, cleaning, shoveling, gardening, like just everyday tasks that need to be done are dangerous, can become dangerous. And so really community level supports are completely lacking. And not everybody has a family, and not everybody has the money to be able to afford the luxury of the pacing, which is your best attempt or your best way at recovering from long COVID. So some kind of supports need to be put in place. Thank you.
So social support, activities for social support. Thank you. Ms. Kaup?
Hi there. I was just going to say, on top of what the others said, I think the education of the medical community is really important at the family physician level, to be getting that information out there about all the dysautonomia kind of symptoms that we have, and about POTS, because so many of us develop POTS, and heart rate monitoring and knowing to rest. Like whenever I hear that somebody has COVID, I'm like, make sure you rest, make sure you rest. Don't be stupid like me, still running 5 kilometers, and pushing it. And so the education needs to go to all of the initial providers, physicians, allied health professionals, whoever you might first see. And then it just somehow, I know Alberta has sort of tried to address this by developing practice guidelines, and then they also have information on their website. And I'm not sure what else is going on in the country. But somehow getting that education out there for people who are living with long COVID, so that they know to rest, and that they know to start monitoring their heart rate and pacing. And I tell you, I talked about pacing before as a professional, but having to actually do it in real life is way harder than you would ever think. So I'll stop there.
So education, and maybe at a societal level, some guidelines. Thanks. Ms. Hanaway?
Yes, so I think I want to add on to what everybody else said. We are a very privileged crowd of people who are at this panel right now. We speak perfect English and we have good education, but this is not the case for a lot of people with long COVID who are forced to keep working and forced to not be able to take time off and support family and whatnot. And so I think, in order to make care accessible, we need to, again, train care providers to recognize long COVID and just have more both community level education and also provider level education, but also a clear biomarker for long COVID, because that has been, lots of money has been poured into that from other countries, but I'm not sure what's going on in Canada in terms of finding a accessible biomarker. And when I say accessible, I mean something as simple as a finger prick, something that we've seen for diabetes, not something that people need to line up months and months to get, or they'll be gaslighted, or they have to pay extra money in order to get this biomarker or go under an MRI machine. So I think that needs to be really fast-tracked in order for folks at a, more who aren't able to pursue care like we are or who aren't fluent in medical education, or just don't have time to do their own research to be able to get diagnosed in long COVID in the first place.
Okay, you touched on some very key points there. Thank you. Dr. Bhéreur?
Yes, I wanted to comment on the disability coverage, but I'll just add something on rest. I really believe in rest, and I really believe that we should look into that. But it's also important, I think, to make sure that people don't see it as a silver bullet and feel guilty if they still have long COVID after resting as much as they can. I, for example, rested completely after COVID. I couldn't actually move because I had moderate to severe COVID. So I rested as even more than properly, and I still got long COVID. So it's important that people understand it's not a silver bullet. It's something that may, and I think, reduces risk, but it's not something that will certainly prevent it. And to answer on the disability coverage, I think long COVID has uncovered holes that were already there on all the programs. People are not aware, navigating through everything. I mean, I have a university degree and even before, for my patients, I had trouble navigating through it. As a person now, I just can't. I can't find my way through it. So that's an issue. And of course, the programs are probably with big holes and do not cover everyone. And there's the problem of the flexibility for partial or episodic disability. And losing the last one, but also the fact that long COVID, most time you have to settle up after 2 years, but we don't know yet after 2 years if we are at the maximum of the evolution. So that's another issue in most programs. So we really have to review all of it.
Yeah, so I appreciate all those answers. There are a lot of questions that need to come from the task force for which we want. So let's try to make it maybe about, short questions, short answers, just so that everyone has a chance to answer. I think to this last question by Dr. Gross, I think Ms. Patino, you have the last answer, and then we'll go on to the other questions from task force members, please.
Thank you so much. I will just add on top of everything that everyone has said, of course, education across the board, from doctors to the general public to patients on how to manage is crucial. Funding is absolutely, it's necessary. It's non-optional almost, there are the provinces that do have post-COVID clinics available to patients have waiting lists that are kilometric because they are not properly funded. They are not properly educated on how to handle long COVID either. Those of us who have been patients to these clinics have to encounter repeating our stories 30 times because there's not a wholesome system integrating where each of the specialists can communicate with each other, who has been doing what kind of results, and who's going to be taking over what. I was referred as a very severe urgent case at St. Paul's. I was supposed to be referred to at least 6 specialists. That was September last year, and to this day, I have been discharged because I've been sick for over 18 months, even though my neurological issues are still bad enough that I can't leave my house, and I only saw 2 specialists, so I never heard from the other ones. Funding, research, while accepting patients at the same time so that we can learn from the patients while still developing funding programs such as the ABI wellness program that is for cognitive rehabilitation that has been adapted for long COVID, funding those kind of programs that can be made available to people right away and getting them back to some sort of normal is absolutely crucial. Thank you.
Super, great. And there's an interesting topic that Dr. Mukherjee from our task force would like to raise. Nazim, are you?
Yeah, I will do it very, very quickly. I just want to ask, I think Susie, if I'm not mistaken, brought it up, but also Sarah, you mentioned is National Patient Registry is how it was put. I see a patient registry as a backbone infrastructure, that could spawn off so many studies, so many knowledge studies that relate to knowledge and so on. want to tap into your experience and connectedness in your province across Canada. Where do we find patient registries right now being developed or developing? How are they being populated? You know, how are the patients enrolled and who's doing it? I know some answers to this, but I want to just put that question to the 8 of you who are here.
Well, I think for the sake of time, we should focus on concrete answers. So if there are patient registries that exist, please share your experience. I think speculations and what could be done, we may not have the time for that. So let's just talk
The
about
only one that I know is Cedrin, Canadian COVID Emergency Rapid Response Network, that has working on a national registry. They are the only people that are following emergency department patients. Thank you.
Are there any other ones that we know about from the other panelists?
I am working on one in Ontario.
And did you want to elaborate on that relative to what Nazim was concerned about, or?
We can talk among the panelists, the task force members later.
Okay. Andre, you had a question in the chat, and then after that, it's Dr. Langley. Andre? Andre, okay. I don't see you or hear you.
Okay, I'm here, sorry.
Yep.
I was on mute. So sorry. That was, by the way, thank you everybody. This was fantastic. The question I had, and this is something that came up in some of our previous task force meetings, is whether in your experience you have identified, again, either yes or no, or some names, probably because of time we can do that, whether you've identified like online resources that can help people first understand long COVID, but most importantly, if they have some symptoms, whether they can follow some algorithms to try to assess whether they have it or not, and then some path that they could follow to get proper help by the healthcare system.
The one that exists is pay out of pocket.
Pay out of pocket, is that what you said?
That's correct.
You mean that's a name, or you have to pay out of your pocket?
You have to pay out of your pocket. Not to be included with the rocket.
Thank you.
Anybody else have a perspective on that?
Carrie Anna.
Okay.
Hi, I would say that online support groups are doing the work that should be done by government to educate patients about their conditions and helping them, giving them tools to bring to their family doctors, to educate their family doctors to go bottom up in terms of helping educate about long COVID. Unfortunately, people are still arriving in our support groups with no, as was said earlier, no knowledge of long COVID, but our support group is creating resources that don't exist and pointing patients who have long COVID in the direction of the few resources that do exist, giving and putting them into their hands and saying, use this to advocate for yourself, to get your elbows out, to get the care that you need. And this is how you do it. This is where the doctors are. This is what your symptoms are. This is what PEM is. And we're doing the work that should be done by our government. And I would like to add that patient partnership is something that needs to be inherent to any creation of tools, educating people about long COVID. Nothing about us without us. And this is also something that needs to be included is patient partnership in the creation of the tools, because we really have the lived experience to make sure those tools are adequately addressing the needs of people living with long COVID.
Thank you.
Okay.
I agree with you.
And I think just for the sake of respecting everyone's time, Dr. Langley has a question, so we will hear it. It will certainly invite answers, and then after that, I'll pass it to Susan Law to wrap this up.
Thanks, John. First of all, I just have to say how impactful hearing your stories has been. You know, as a physician, you get one story, then you have a little break, then you get another one. But to hear so many stories one after the other and how this has changed your lives, honestly, it's I think you've had a great impact on the task force, and thank you for giving the energy you have today to this. My question is about, I just feel this urgency. We need to describe the burden of the problem, and we're getting there. I think there's been a lot of studies to say this is how much illness is associated with this, but we have to move to understanding mechanisms of disease, as Manali was saying, and then prevention, like not just primary prevention, preventing getting COVID, but secondary and tertiary, and treatment interventions that will get people back to health. And that, as you say, it's got to involve the patients. Are you seeing internationally any models where there's a national strategy, or ways that advocacy groups or patients are interacting with researchers or the healthcare system to get this work done? And how are you funding yourselves? How are the advocacy organizations getting funded?
I pay out of my pocket.
So Ms. Goulding, your group, you pay out of pocket for your group to be involved with researchers?
I pay out of pocket for the cost of running the group. I have taken on a job. I had to change careers to be able to allow me to do all the work that I do. I'm a medic in the film industry, and so I can take business meetings and things while I'm on the job. But yeah, anything that involves the group, I pay for out of pocket.
Ms. Hannah Wei, you have your hand up.
Susie, I completely empathize with what you're saying with paying out of pocket. For 2 years, the Patient-Led Research Collaborative is completely bootstrapped by volunteers. It's only recently that we've gotten some funding, not from academia, not from governments, but from a cryptocurrency funder. So it is very, very hard to get support, financial support for patients to develop research, but also, develop care guidelines and help other patients. There's no structure to include us in the long COVID response so far. But we are, every day, we are fighting for seats at the table in order for not only for our voices to be heard, but also for our strategies, our expertise to be woven into the long COVID response across the globe. In terms of what I see going forward, the Patient-Led Research Collaborative is currently working with the PCORI on the US side, which is the Patient-Centered Outcomes Research Institute. And we're developing a project in which patients are leading to develop a guideline as to how patients can collaborate with researchers, not just as consultants of research, not just as, hey, let's have your group, send out some surveys. That's not, to us, that's not, patient involvement, but being at the table at the beginning to come up with hypotheses, come up with research questions, all the way to co-running analysis with patient-reported data, all the way to writing reports that target patient communities that are understandable to the general population. So this is what we see going forward in terms of incorporating patients into the long COVID response.
Excellent. Thank you very much. I think for the sake of time, because we're over the 6 o'clock time limit and we realize everyone has other things to do. Susan?
Thanks so much. I just know that this could go on for a long time, but I just want to be respectful of the energy levels and people's times. It's cutting into dinner here in this time zone anyway. But I just want to say thank you so much. This has been such a deep and profound and broad, actually, understanding of your experiences and your perspectives of what the challenges are, some of the solutions that you see as being appropriate and ultimately can be considered by decision makers in Canada. So thank you so much. This has been absolutely brilliant. My suggestion, because I know that there are more questions both in the chat and in the minds of the task force members, I think that perhaps what we can do do to help is to gather up these questions. And if the panelists are willing, you are not obligated. We could send that list of questions out and people could jot answers back, call us with your comments so that we can collect those answers as easy as you see would be appropriate for your situation. And then we could give it sort of maybe a 1.5 week sort of time frame. I'll consult with my colleagues at the Chief Science Advisor's office to see if that's feasible. But does that sound acceptable to everyone so that we can continue this conversation, but just in a disassociated way? Is that okay? Thumbs up. Okay, that's fantastic. Thank you everyone so much. I wish you enjoy your evening and just know that this has been incredibly useful. So thank you everyone.